Welcome to another session of Rounds in the Fast Lane, the channel which I created to help interns, residents, and medical students with the most common clinical scenario that you will come across in the hospital setting. Just like my other lectures, I'll be uploading these notes in the link in the description box below. So today's discussion is on heart failure. Now, what is the heart failure? As per the books, heart failure is a disorder in which the heart is not able to pump blood to meet the demands of the body. But to understand this for practical purposes, I've drawn this diagram over here. Think of it as two motors, one on the left side, one on the right side, and with the lungs in between, and this pipe system, a closed circuit of this pipe system with the flow of the blood in the direction as shown with the arrow over here. Now think what's going to happen if this motor on the left side fails. When this fails, there's going to be backup of the fluids in this pipe, increased pressure, which will eventually increase the pressure in the capillaries in the lungs, and eventually increase pressure on this motor leading to its failure, and hence increase pressure overall in this pipe over here. Similarly, what's going to happen if the problem is primarily in the lungs? Think about advanced cases of COPD, emphysema, in acute cases of pulmonary embolism, or sometimes in cases of interstitial lung disease. Whenever there's problem over here, there's going to be increased pressure in this pipe, which will eventually lead to the failure of this motor and eventually increase the pressure in these pipes over here. Similarly, if there is some primary problem over here in this motor on the right side, there's going to be increased pressure first on this side of the pipes and then eventually increased pressure in other sides in this closed circuit. So this is something that if you can think about this diagram, every time you have a patient with heart failure, you can easily pinpoint where exactly is the problem. Is it primarily in the left motor, primarily in the lungs, or primarily on the right side of the motor? So this is something that you can think about every time you admit a patient. Now, for this lecture, whenever I'll be talking about, whenever I'll be saying the word heart failure, I'll be primarily talking about the left-sided heart failure. Because remember, the most common cause of right-sided heart failure is left-sided heart failure. It can be either left-sided heart failure leading to increased pressure and causing pulmonary edema, which eventually leads to the symptoms of the right side, or it can be isolated right-sided heart failure, which I'll discuss in another lecture. So left-sided heart failure leading to right-sided heart failure and the symptoms of right-sided congestion is called as biventricular failure. So for this lecture, the most important one that we'll be talking about, whenever I say the term heart failure, it will be primarily, we'll be talking about either left-sided or biventricular failure. So let's try to understand the different terminology we use for the heart failure, or mainly left-sided heart failure. That is, heart failure with preserved ejection fraction when the EF is more than equal to 50%, heart failure with reduced ejection fraction when the EF is less than or equal to 40%, and heart failure with mid-range ejection fraction when it is 41 to 49%. Now, first, let's try to understand HFpEF. Now, think about a person who goes to the gym every day and lifts weight on one particular muscle. When you go on adding weight on that muscle, it leads to the hypertrophy of that muscle. Similarly, if a patient has long-standing hypertension, when the heart has to pump against a high afterload, it leads to the hypertrophy of the muscle of the left ventricle. So because of this hypertrophy, there's going to be eventually increase in the size over here and decrease in the size of this cavity. So there's going to be impaired filling in this left ventricle. So ejection fraction is a ratio of stroke volume and end diastolic volume. Now, because of the impaired filling of this left ventricle, the end diastolic volume is going to be reduced. Since the end diastolic volume is going to be reduced, the stroke volume, the amount of fluid that comes out of this heart is also going to be reduced. But remember that both of them proportionately go down, and hence the heart fails even though the ejection fraction is preserved. Now think about another patient who has a massive MI all of a sudden, and it leads to the failure of the muscle itself. Now the heart is not able to pump. There's failure of the pump to push the fluid out of the heart altogether because this wall has been damaged. As a result, the stroke volume goes down way more as compared to the end diastolic volume. So that's why the ejection fraction falls, and we call it HFrEF, that is heart failure with reduced ejection fraction. Now, this patient with left ventricular hypertrophy due to hypertension, if he also has diabetes, coronary artery disease, eventually ends up having an MI, he can have HFrEF. HFpEF can lead to HFrEF, but remember that a patient coming in with a diagnosis of HFrEF may or may not have HFpEF in the past. So this is something that you have to remember. Now, moving on to the causes of heart failure. What leads to heart failure? Let's discuss the causes of heart failure, and then we'll talk about what leads to acute exacerbation of heart failure. Now, the number one cause of heart failure is coronary artery disease or ischemic heart disease, as I explained over here. Now, this terminology was explained with this example of coronary artery disease or ischemic heart disease, but heart failure can happen due to multiple different reasons. So, the second most common cause is hypertension. Then the other causes are valvular heart disease. Now, imagine if the patient is having severe mitral regurgitation. Every time the heart tries to pump the blood out, due to the regurgitation, there is excessive fluid that comes back into the left ventricle. Or imagine if a patient is having severe aortic stenosis. Now, this left ventricle has to pump against a very tight pipe. So that will again lead to hypertrophy and eventually failure of the heart. Then arrhythmias. Arrhythmias is also one of the most common causes of heart failure. Then endocrine disorders like thyroid disorders, both hypo and hyperthyroidism. Drugs and toxins, alcohol, cocaine, cardiotoxic medication. Then infections like viral myocarditis, HIV, Chagas disease, Lyme's disease. And then something that is very important that you need to understand over here is cardiomyopathy. Cardiomyopathy means problem of the muscle itself. It can be dilated, restrictive cardiomyopathy where the muscle becomes very stiff, hypertrophic cardiomyopathy, peripartum cardiomyopathy, and Takotsubo cardiomyopathy. Now, previously we used to use the terms ischemic cardiomyopathy, valvular cardiomyopathy, hypertensive cardiomyopathy, but we do not use them anymore because cardiomyopathy term is mainly used when the problem is in the muscle itself and not secondary to, for example, coronary artery disease leading to ischemia, leading to damage of the muscle. So that's why we no longer use the term ischemic cardiomyopathy. Now, it can be due to multiple reasons, like, for example, storage disorders, infiltrative disorders, hypertrophic obstructive cardiomyopathy, and Friedreich's ataxia. Now, dilated, restrictive, hypertrophic, these are morphologic classification, and each of these different causes can lead to different morphologic types of cardiomyopathy. For example, dilated cardiomyopathy can happen due to multiple different reasons, which can be genetic, systemic disorders. It can be idiopathic. It can also be caused by alcohol, cocaine. These can lead to dilated cardiomyopathy. Then amyloidosis, hemochromatosis, sarcoidosis, or a disease like scleroderma. All these conditions can lead to restrictive cardiomyopathy. Then also amyloidosis, Friedreich's ataxia, Fabry's disease, glycogen storage disease. These all can lead to hypertrophic cardiomyopathy. So these causes can lead to these kind of morphological picture of cardiomyopathy. Then some of the other causes are autoimmune, nutritional causes. Autoimmune, like for example, as I said, in case of scleroderma, in case of SLE, then nutritional causes like, for example, thiamine deficiency, selenium deficiency, anemia, which is one of the also important causes of acute exacerbation, then congenital heart disease leading to shunts, and then radiation. Now, let's try to understand the acute exacerbation of heart failure. Now, whenever you admit a patient in the hospital with acute exacerbation of heart failure, the first thing that you should think about is why did this patient go into acute exacerbation? If the patient was stable at baseline, taking all his meds, is adherent with all his meds, then what exactly happened? So, as I said, the number one cause of acute exacerbation of heart failure is patient not taking his med, non-adherence to medication, then excessive salt and water intake. And then all these first four causes of heart failure can also lead to acute exacerbation of heart failure. That is, if the patient has some new ischemic event. A patient coming in with acute exacerbation, you should have a high suspicion if they have a new ischemic event. Uncontrolled hypertension, valvular heart disease. If the patient has severe valvular heart diseases and if they are not corrected either surgically or through procedures, the patient can go back and forth into acute exacerbation of heart failure. Then arrhythmias. Now, for arrhythmias, I'll give you an example. Every time a patient is admitted, the cardiologist will ask you to check the patient's telemetry. Sometimes the patient can have, let's say, for example, AFib that is not either not rate controlled, or the patient has failed rhythm control strategy, or if the patient is not taking medications, going back and forth into AFib, going back and forth into a very rapid ventricular rhythm. This can lead to acute exacerbation of heart failure. Then, for example, if someone has high PVC burden, that is premature ventricular contraction. I'll explain premature ventricular contraction in detail in my EKG sessions. But for example, if the patient is having a high PVC burden, more than 10-20%, and this patient goes into acute exacerbation, then we know that this high PVC burden has to be dealt with to deal with repeated episodes of acute exacerbation. So that's why it's important to monitor the patient's telemetry and see if there is any arrhythmogenic event that is leading to these acute exacerbations. This is something that you can mention in your note every time you admit a patient, that this is the possible cause of the patient's acute exacerbation of heart failure. Then let's start with the clinical evaluation. What are the common symptoms and the signs of heart failure? Now, let's start with the symptoms. Now, every time we ask a new resident or an intern, what do you think is the symptom of heart failure? The number one thing that comes to the mind is shortness of breath. And if we ask about sign, the number one thing that we think about is rales or crackles on auscultation. Now, remember that shortness of breath and crackles on auscultation can happen in multiple different conditions. So every time we are admitting a patient or evaluating the patient, the first thing that you should think about is what is more specific of heart failure. So PND and orthopnea, that is paroxysmal nocturnal dyspnea, and orthopnea are the two symptoms which are more specific for heart failure. Shortness of breath at rest or exertion, progressively increasing shortness of breath. Patient having shortness of breath. First, he's able to walk 3 blocks. Now he's only able to walk 1 block. And then, for example, they become short of breath on routine activity. And then they become short of breath even just by getting up from their bed or going to the bathroom. And then they become short of breath at rest. So this is more sensitive than specific of heart failure. And patient can also present with chest pain in case of heart failure. Peripheral edema, then they can have abdominal distension due to that fills up ascites. Then right upper quadrant abdominal pain due to congestion in the liver, and fatigue and weakness. These are the common symptoms of heart failure. But remember, whenever you're admitting any patient, always ask about PND and orthopnea because it is more specific. Then talking about the signs. Similarly, rather than crackles in the lungs, JVD and S3 are the two more specific signs of heart failure. So if the patient is having JVD, and if you're not able to see the JVD, you can press on the liver, and if the hepatojugular reflex is positive, that is very specific. And similarly, S3 and displaced apical impulse. Now remember that S3 is very observer dependent. It is not necessary that it's always going to be present. You need to have a left atrial end diastolic pressure of more than 20 mm of Hg and left ventricular end diastolic pressure of more than 15 mm of Hg to actually appreciate S3. And still, like if you're, it is possible that if a person does not have a lot of experience, this can be missed. So JVD is something that you should always look for, even if you're not able to appreciate the S3. Then, of course, crackles in the lungs, which is more sensitive but not very specific of heart failure. Then peripheral edema, and as I said, ascites, hepatomegaly. Patient can have right upper quadrant tenderness, splenomegaly, scrotal edema, pulsus alterans. And never forget to check the patient's perfusion, because the patient, when they come in, they can be in cardiogenic shock. So look at the extremities, if they're cold or clammy, if the patient has altered mental status and a weak pulse. And then ordering the investigations. Now, as I said, it is important to know the causes of heart failure, because when you know the causes of heart failure, every patient who comes in with either acute exacerbation or new onset heart failure, you will know what investigations to order to look for the causes, what exactly led to this patient heart failure. So let's start with the EKG. Now, always remember, you order the tests which are to look for the most dangerous conditions. Like, for example, if the patient had a STEMI and came in with heart failure, if the patient had significant arrhythmia, which has to be immediately dealt with. Like, for example, if the patient needs to be cardioverted, if the patient needs to be sent to the cath lab immediately. So that's why you start with those tests, which will give you an idea about the most dangerous conditions. So that's why an EKG is the first thing and the most important thing. That you can order a chest X-ray as well to look for the congestion in the lungs. Then cardiac enzymes. Troponin is, of course, that you will order. It's a part of the ischemic workup. And then the BNP. Now, remember that BNP is something that will help you to support the diagnosis or exclude heart failure. Now, it has to be interpreted in the clinical context because there are a lot of conditions. Like, for example, it's going to be falsely high in case of in case of elderly, in case of sepsis, in case of renal disease. You'll see a falsely high BNP. In case of obesity, it can be falsely low. And in the patients who are taking sacubitril and valsartan combination, it's going to be very, very high. So, how you interpret the BNP, it depends on the clinical condition. Then transthoracic echocardiogram. First thing is transthoracic echocardiogram to look at the patient's wall motion, to look at the patient's valve to see if they have any structural heart disease. Then a basic set of labs, CBC, complete metabolic profile, electrolytes. Now, ABG can also be ordered if the patient is severely hypoxic, if you're suspecting hypercapnia as well, if the patient has other problems, like, for example, COPD exacerbation, and the patient also has heart failure, and you do not know at this time which is the exacerbation. Is it exacerbation of heart failure or COPD or both? So this is an important test that you can order, and I'll be explaining this in detail in the end of the lecture. Then tox screen, as I said, one of the important causes of heart failure is alcohol, cocaine, drug use. So you'll order a urine drug screen and then a TSH. Now, every patient who comes in with new onset heart failure, especially HFrEF, has to undergo an ischemic workup. You can do a CT coronary angiogram, a stress test, or a left heart cath, coronary angiography, and angioplasty. Now, remember, a lot of times the cardiologist might choose directly to go for a left heart cath, or if there is a positive stress test, patient has significant angina and the heart failure is unexplained. In these cases, a lot of times the cardiologist might directly proceed with a left heart cath. But either way, remember that every patient with new onset heart failure has to undergo an ischemic workup. Now, other workup like right heart cath, cardiac MRI, an autoimmune panel, and protein electrophoresis. These workups are usually ordered if you're suspecting that the diagnosis is something uh, other than the ischemia. Now, right heart cath, the indications and when and how do we do it, I will be explaining in the end of the lecture. Let's talk about cardiac MRI. Now, cardiac MRI is a very good investigation to look at the muscle, the wall, the valves, and the coronaries. It is especially ordered if you're suspecting cardiomyopathy because it is a really good test for the evaluation of cardiomyopathy and it gives better assessment of the infiltration and fibrosis. If the echocardiogram is inadequate, even then you can order a cardiac MRI. It is also done for myocardial viability studies, and cardiac MRI is one of the gold standards to assess the right ventricular size and function. So imagine if a young patient comes to you, all of a sudden has HFrEF, EF is 20%. You see on the first time evaluation, do an echocardiogram, the EF is 20%. Patient is 35-year-old, no comorbidities, and you do ischemic workup, it is negative. So this patient needs to be sent for a cardiac MRI. Let's say, for an example, if the patient comes to you and has on the transthoracic echocardiogram, you see a restrictive pattern or hypertrophic pattern, and the patient has low voltages on the EKG, and you're suspecting amyloidosis, then the patient needs to go for a cardiac MRI. So this is a really good test. The only problem is not every center has a cardiac MRI. So you need to think about which patient needs it and in which patient you can rule out the other causes first. And as I said, if you rule out the other causes, and an autoimmune panel can also be ordered, and then protein electrophoresis as well. So this is how you will investigate whenever the patient comes in with heart failure. Now let's talk about the classification of heart failure. Now there are two types of classification we're going to talk about. That is AHA classification, American Heart Association, and based on the symptomatology, the New York Heart Association classification. So AHA classification is stage A, B, C, and D. Stage A is when the patient is high risk of heart failure but does not have any structural heart disease or any symptoms of heart failure. So you do an echocardiogram and the patient does not have any left ventricular hypertrophy, does not have any problems with the valves, does not have any signs suggesting cardiomyopathy. So in any wall motion abnormality. So in these cases, we'll say that the patient is stage A, but is at high risk. Then stage B is when the patient does have structural heart disease but does not have any symptoms. Stage C is when the patient does have structural heart disease and also has symptoms. They can be either current symptoms or prior symptoms. And then stage D is refractory heart failure. Now, New York Heart Association classification is class 1, class 2, class 3, class 4. That is, class 1 is the patient does not have symptoms at rest and does not have symptoms at physical activity. Class 2 is when the patient does not have symptoms at rest but has symptoms on ordinary physical activity. Like, for example, patient climbing 1 or 2 flight of stairs in their house, going and doing laundry. All these things of ordinary day-to-day physical activity, household work, they become short of breath. So that's class 2. Class 3 is when the patient does not have symptoms at rest but has symptoms at even mild physical activity. Like, for example, patient trying to get up and going to the kitchen and going to the bathroom from their bed, and they become short of breath. But they are not short of breath at rest. So that's class 3 uh, symptoms. And then we have class 4, that is the patient has symptoms at rest and of course also at physical activity. So if the reason I'm telling this is that, let's say when you're writing a note admitting a patient, and then if you say, let's say you write patient has stage 3, stage C AHA and class 3 NYHA heart failure. So the person, whoever is a consultant or anyone who's reading a note, they can easily understand that where does the patient stand. If it's stage C and it's class 2, stage C, class 3, stage D, of course, it's going to be class 4. Or stage B and class 1. So any patient, if you're writing the note in the clinic and or writing the note in the hospital, you can write this classification and it will give a better idea of where does the patient stand. Now, before we go to the management, let's just do a short review of what does the recommendation class mean. That is, recommendation class based on the evidence, how strong the evidence is to recommend this therapy. So there's class 1 recommendation, which means that you must do it. That is, enough studies and randomized control trials have been done to say that the treatment has way more benefit than the risk. Class 1, you must do. Class 2A recommendation, which means that you can do it. That is, we have good amount of evidence to say that the benefit is more than the risk. Then class 2B is you may do it. That is, the benefit may be or equal to more than the risk. And class 3 recommendation is you do not do it. That is, the benefit is definitely lower than the risk. So whenever I'll talk about the recommendations in the next part of this lecture, and I say class 1, it means that it is the norm of treatment, that is the GDMT, to treat this condition. And then before we discuss the treatment, the diuresis, I would like to talk about cardiorenal syndrome. What is cardiorenal syndrome? So let's say a patient comes in, has heart failure. Now, due to the heart failure, the heart is not able to pump effectively, and it will lead to the decreased perfusion to the kidneys. Now, remember that the kidneys do not have a way to tell if it is the problem with the heart that is leading to the decreased perfusion, or is the body intravascularly depleted, that there is not enough volume in the pipes. That is why there is decreased perfusion. It's just going to think there is low perfusion, and it's going to activate renin, angiotensin, aldosterone system. And due to this, there's going to be increase in the vasoconstrictors. The angiotensin is going to come, and then there's going to be increase in aldosterone. So there's going to be fluid and water retention, and there's going to be salt and water retention, and there's going to be increase in the afterload and preload. Due to this increase in the afterload and preload, it's going to worsen the heart failure, and the heart failure again is going to worsen the perfusion. So this way, the heart and kidneys enter in a vicious cycle, which is called as cardiorenal syndrome. The reason I'm explaining this now is that an important way to get the heart out of this cardiorenal syndrome is to diurese. Now, the picture is going to look like pre-renal cardiorenal syndrome, pre-renal AKI, that is acute kidney injury. Now, remember that in other cases of pre-renal, like for example, if the patient is very, very dehydrated, hemorrhagic shock, in all these cases, the pre-renal AKI, we treat it with volume resuscitation. Whereas in cardiorenal syndrome, we treat it by actually diuresing the patient. I'll explain this concept in detail when we do AKI, but this is something that you have to understand, that how cardiorenal is different from other causes of pre-renal AKI. Now, the cardiorenal syndrome I've explained over here is mainly type 1 cardiorenal syndrome. That is, It happens in acute exacerbation, which leads to acute kidney injury. There are also other types of cardiorenal syndrome, that is type 2 cardiorenal syndrome, in which chronic heart failure leads to progressive CKD over a period of time. Type 3 cardiorenal syndrome, in which abrupt kidney dysfunction, for example, let's say from renal ischemia, it leads to cardiac dysfunction. Type 4 is when CKD leads to cardiac dysfunction. So these are different types, but for now, the most important that you have to understand is type 1 cardiorenal syndrome and acute exacerbation, because this is how it's differently treated as compared to other causes of prerenal AKI. And also, the thing about cardiorenal syndrome, different from the other causes of prerenal AKI, is that when you give diuretics in cases of AKI, in other causes of prerenal where there is intravascular depletion, the patient's kidney function is going to worsen. Whereas in cardiorenal syndrome, you will see an improvement in the kidney function because the congestion is improved after you diurese the patient. So a lot of times you'll see that the patient comes in with elevated creatinine in case of acute exacerbation of heart failure. You diurese them and the creatinine gets better, or there you will see a small bump in the creatinine elevation and then it starts going down. So this is a classic of cardiorenal syndrome. Now let's talk about the management of heart failure, management of acute exacerbation and management of heart failure at baseline. So we'll go one by one over the topics in acute exacerbation of heart failure. The important modalities of management is diuresis, then oxygen supplementation, then vasodilators, and then role of beta blockers in case of acute exacerbation. And then whenever patient comes in due to acute decompensated heart failure, you put them in propped up position, seated position. Let's talk about the diuresis first. Now, how do we diurese the patient and what are the strategies to diurese? The amount of diuretic dose that you'll be choosing depends on two things. That is the patient's renal function and whether or not the patient took diuretics at home. Now, let's think about each and every example. A patient comes in with acute exacerbation of heart failure. He has a history of HFrEF for, let's say, 5 years and takes furosemide 20 milligram PO daily at home. Now, based on the dose trial, whenever the patient comes in the hospital, we have to use 2 to 2.5 times the home dose. So look at this conversion over here between the different doses of different loop diuretics. That is, furosemide 40 milligram oral is equal to 20 milligram IV. It is equivalent to torsemide 20 milligram, and torsemide has a good bioavailability. So IV and oral is both 20 and 20, and bumetanide is both 1 and 1. So for PO loop diuretic, you can remember this 40 is to 20 is to 1, 40, 21 for furosemide, torsemide, and bumetanide. And when you convert it to IV, it remains same for torsemide and bumetanide, but furosemide, it's 2 is to 1. So this patient who has a history of HFrEF takes furosemide 20 milligram at home, comes into the hospital with acute exacerbation. So we have to use 2 to 2.5 times the home dose. So 20 milligram of oral furosemide is equal to 10 milligram of IV, as I explained. And now inpatient requirement in acute decompensated heart failure is you're going to use at least twice the dose. That is, it's going to become 20 milligram of IV furosemide as the first initial dose, at least 20 milligram of IV. Now let's talk about another patient. Now, let's say the patient has a history of HFrEF, takes 20 milligram of PO, furosemide at home, and he comes in with acute decompensated heart failure, and you calculate his home dose is 20 milligram of, and you calculate the inpatient requirement as 20 milligram of IV furosemide. Now, this patient has a creatinine of 2. Now, remember that the loop diuretics act from the luminal side. So if someone's creatinine is 2, they're going to require a higher amount of the dose for them to concentrate in the loop and for them to have adequate diuresis. So this patient's requirement will be approximately equal to 2 times the 20 that you calculated based on the home dose, and it's going to be 40 milligram of IV furosemide. Then if the patient's creatinine is 3, it's approximately going to be 3 times the 20, that is 60 milligram of IV, and so on. So if you're admitting a patient who has HFrEF, EF is 20%, comes in with acute decompensated heart failure, and the creatinine is 3 or 4, giving them small doses of furosemide 20 milligram IV, it's unlikely that you're going to achieve a good amount of diuresis. So you always have to look at this, the patient's creatinine, before you decide how much loop diuretic you want to give. Then another patient, if you think about an example, who does not use any furosemide at home, any loop diuretic at home, is pretty euvolemic at baseline, and the kidney function is also normal. So if they come in and you're choosing an initial dose, you can start with 20 to 40 milligram of IV furosemide. So you always look at these two things, whether they're taking diuretic at baseline or not, and how is their kidney function, and then you decide how much furosemide to give. Now, this is about the starting dose. And remember that at some places, the provider might choose to start the patient on a drip, furosemide drip. You can do either a drip or an interval bolus dosing, but studies have shown that there's no difference between the two. So you can choose either of the two. More commonly, interval bolus dosing of furosemide is what is used to diurese the patient. Now, this is going to be the initial dose, but then how will you progress the care? So your goal of diuresis is 100 to 150 cc's per hour in the first 6 hours of urine output. And if you're not able to see this much amount of urine output, you're going to double the next dose. So diuretics are typically given as twice a day or once a day dosing when you do the interval bolus dosing, and you have to achieve at least 1.5 to 3 liters in the first 24 hours. If you're not able to achieve this, you keep on doubling the dose, the next dose for diuresis. Now, let's say you're giving furosemide 80 milligram, 100 milligram, even 120 milligram. You're doing BID dosing. You went up to the max dose, and you're seeing that the patient is not diuresing well, is still congested. Now, this can happen if the patient's creatinine, if patient is CKD stage 4, and patient is not responding well to furosemide. You step up the diuretics you start with torsemide or bumetanide, and you go to the max dose. Even if then the patient is not diuresing well, then you do something called a sequential blockage. That is, you do thiazide diuretic metolazone first and block the distal convoluted tubule, and 30 minutes later you give the patient furosemide, and then you will achieve better diuresis. Even if this is not working and the patient is still congested, or if the patient is not making any urine, you go for hemodialysis. Now remember, there are different causes of patient not responding to diuretics. Either the kidneys are really damaged, or the patient is in cardiogenic shock. So this I'll be discussing later. You have to remember that you also have to evaluate the patient, that why are they not responding to diuretic? Is it just because the patient has CKD, or if the patient is having impaired perfusion going into cardiogenic shock? And in those cases, you have to do ionotrope assisted diuresis, which I'll be discussing later. So this is how you step up your diuretics. First, you go with furosemide, you max out the dose, and then you can change to torsemide, or you can do sequential blockage. And eventually, when I'll be discussing AKI and hemodialysis in the later sessions, one of the indications of hemodialysis is volume overload, non-responsive to diuretics. So then you proceed with hemodialysis to remove the volume. Then talking about one recent trial, one recent update that was published for heart failure, the ADVOR trial. Now, what did the ADVOR trial said? It showed that there was successful decongestion in the patients with acute decompensated heart failure, in whom loop diuretic was used along with acetazolamide. But however, in this trial, there was no difference in the overall mortality or hospitalization rates, but there was definitely successful decongestion. So you could use acetazolamide in the initial phases of diuresis with the loop diuretic. In this trial, they gave 500 milligram of IV acetazolamide with the loop diuretic. But remember that the patients who had a low GFR less than 20, who were already on acetazolamide or taking SGLT2 inhibitors, or whose blood pressure was on the lower side, less than 90, these patients were excluded from the trial. So anytime you interpret a trial in the clinical context, whether it's heart failure or any other condition, always remember you must know what were the inclusion and exclusion criteria for the trial, because your patient might or might not fit the criteria, and you will not be able to use the results of the trial if the patient was in the exclusion criteria for that trial. So always remember that while interpreting any trial. So this is some recent update, and you can start using acetazolamide with the loop diuretic in the initial phases if the patient fits the inclusion criteria. Acetazolamide is also used in some of the cases, like for example, if you're giving a loop diuretic and the patient starts becoming alkalotic, significantly alkalotic, and has no other reason for them to have elevated bicarb, then in those cases, A lot of times cardiologists will use acetazolamide with the loop diuretic. The thing about acetazolamide is that it quickly shifts the patient's acid base balance towards the acidotic side. So you have to be careful while using it to keep an eye on other electrolytes and to keep an eye on the bicarb. And especially be very careful if you're discharging someone on acetazolamide, because these patients have a very high chance of becoming quickly acidotic. So keep that in mind if you're using acetazolamide. So some of the places where you're gonna have to be very careful about diuresing is the patients who are preload dependent. If the patient has severe aortic stenosis or hypertrophic obstructive cardiomyopathy, and they come in with acute exacerbation of heart failure, you cannot diurese them like otherwise in other causes of heart failure, because if you suddenly drop their preload, you're going to cause more harm, and it's going to be dangerous for them for sudden drop in the preload. So these patients have to be, if they're acute, if they come in acute decompensated heart failure or congested, and you're trying to diurese them, it has to be done slowly and has to be more closely observed. And all other causes of preload dependent heart failure, you have to be careful about diuresis. So these things are something that you will keep in mind. You'll evaluate initially before you start diuresing the patient to make sure they're not preload dependent. Then coming to the role of oxygenation, the role of non-invasive ventilation. If the patient is hypoxic, we're going to give oxygen supplementation. But what about using non-invasive ventilation? Now, there are particular indications and the benefits. So studies have shown that the non-invasive ventilation, typically we use CPAP or BiPAP if the patient is also hypercapnic. Non-invasive ventilation helps reduce the need for intubation and improves the clinical outcome. Now, there are different mechanisms which are thought about how they actually help. This is that they help reduce the preload. They also prevent alveolar collapse. They help you recruit more alveoli in the hypoxic patient, and they also help with reduction of the left ventricular afterload. So these are some of the mechanisms, but always remember that you, at the same time, when you're admitting and starting management, you have to think about when or not to intubate the patient. So if the patient is having altered mental status, reduced signs of perfusion, patient is in cardiogenic shock, patient is not able to maintain the airways, is very tachypnic, using accessory muscles of respiration, is in a lot of distress. There are any other contraindications to NIV. If the patient is at high risk of aspiration, if the patient is having an active GI bleed, and if the patient is hemodynamically unstable, in all these patients, you will just go ahead and intubate the patient rather than using NIV. So NIV will help you if the patient is coming in and you're thinking about acute exacerbation, pulmonary congestion, and you want to reduce their preload as well, along with providing oxygen. So this is something that you can do in the inpatient setting. Then talking about the role of vasodilators in acute exacerbation, I always remember whenever the patient comes in, we always think about quickly diuresing the patient, reducing the preload. But a lot of times, this is something that we have to also take into account. That is the patient's afterload. If the patient is coming in with a very elevated blood pressure, you have to remember that if you diurese the patient, it's going to help them with lowering their blood pressure to a certain extent. But if the afterload is not controlled, they will keep going back and forth into flash pulmonary edema again and again, even if you diurese them. So the afterload reduction has to be kept in mind when you're admitting a patient. That what is your strategy for afterload reduction? So if the patient comes in with significant hypertension, you can use a nitroglycerin drip. It helps with the reduction of preload, or nitroprusside drip, which helps you with the reduction of afterload and preload. The problem with nitroprusside is that it leads to cyanide toxicity, and that's why it's not very commonly used these days. But nitroglycerin will help you lower the patient's blood pressure. The problem with nitroglycerin is the patient can have headaches, and a phenomenon of tachyphylaxis is pretty common. Now, if the patient's renal function is normal, the patient is not in AKI, you can also consider using ACE and ARBs, early introduction of ACE and ARBs. You can also use IV enalapril, as I have explained in my previous session of hypertension, for afterload reduction. Because remember, these medications like nitroglycerin, nitroprusside, they are short acting. And once you stop the drip, their action is going to wear off and the patient is going to become hypertensive again. And then they're going to go into flash pulmonary edema again. So you want to use a medication that's going to remain in the system for a little bit longer period of time and prevent afterload elevation so that they don't keep flashing again and again. So you can consider if ACE and ARBs, if the kidney function is if the patient is not having renal dysfunction, acute renal dysfunction, in these cases, early introduction. The other agents that you could use are, for example, hydralazine, isosorbide dinitrate. You can also introduce oral calcium channel blocker if you're concerned that the patient will keep going into hypertension, if you want to control the afterload. Then coming to beta blockers. Now, let's say if the patient has a history of HFrEF, as I'll be talking about after this, about the management of HFrEF, if they're already on a beta blocker, what do you do? Now, we know that you will not start a beta blocker if the patient is in acute decompensated heart failure, but you will also remember that if the patient is already taking it, especially if the patient has a history of HFrEF, and if the patient is already taking a beta blocker, you will not stop beta blocker all of a sudden, because stopping beta blocker in acute decompensated heart failure all of a sudden leads to reflex tachycardia and worsening and is associated with higher mortality. So what do you do if the patient is already taking it? You either lower the dose to half or you can lower the dose to minimum. So let's say if the patient is taking carvedilol 25 milligram twice a day, you can lower it to either 6.25 milligram twice a day or 3.125, but you will not stop it all of a sudden. That is something that is very important. Now let's talk about the patient. Now you've managed this patient with acute exacerbation of heart failure. Patient is now euvolemic or on the drier side, and we're discharging the patient. What are the management strategies for heart failure, CHF? So remember that whenever the patient is in HFrEF, you have to start the patient on all the medications which have shown mortality benefit. Now, the medications like ACE/ARBs, or nowadays what we use is a combination of valsartan and sacubitril, beta blockers, aldosterone, mineralocorticoid receptor antagonist like spironolactone, SGLT2 inhibitors. These medications have shown mortality benefit in case of HFrEF. So that's why they are class 1 indication, as I said before, recommendation class 1. That is, you must start on that a patient with HFrEF on all these meds. Now, you can start all of them together on a very low dose and up titrate them, or you can also introduce them one by one. Nowadays, we mainly, most of the times, we can start the patient on all these if the patient is having HFrEF, and then up titrate them. But the patient with HFrEF should be on these 4 classes of medications. So as I said in my previous session on hypertension, if you're starting someone on ACE, there are different doses. Like, for example, one that will help you control the blood pressure. And if the patient's pressure in HFrEF is on the lower side, you can start on a very, very minimal dose. Like, for example, lisinopril 20 milligram or 40 milligram is for blood pressure. But if the patient's pressure is low in case of HFrEF and you want to give it for mortality benefit, you can give the very minimal dose. Like, for example, lisinopril 2.5 milligram, 5 milligram. These doses will not lower the blood pressure a lot, but they will help in the mortality benefit in cardiac remodeling in case of HFrEF. Similarly, beta blockers. Now, remember, not all the beta blockers have been studied for mortality benefit. There are 3 beta blockers. A lot of times you'll be asked these questions in the rounds, that which beta blockers have shown mortality benefit. So that's carvedilol, metoprolol succinate, not metoprolol tartrate, and bisoprolol. These 3 beta blockers. Now, how to use these beta blockers in the clinical context? Like, for example, I explained in the previous session in hypertension. Like, for example, carvedilol is a non-selective beta blocker. So it will help you control the blood pressure more as compared to a cardioselective beta blocker like metoprolol succinate. So if the patient is having high blood pressure in case of HFrEF, you would consider starting carvedilol rather than metoprolol succinate. If the patient's blood pressure is normal or on the lower side and you want to start a minimal dose for mortality benefit, you can choose metoprolol succinate over carvedilol. So these are different ways you can use a beta blocker. Then mineralocorticoid receptor antagonist, you can start with spironolactone. Remember that spironolactone cannot be started in the patient who has a potassium of more than 5.5, has a high tendency of going into hyperkalemia. So this is something that has to be that you have to remember and have to be monitored, that if you start ACE and ARBs and spironolactone together, a lot of times the patient does have a problem of going into hyperkalemia. So this is something that has to be monitored, and you have to start with minimum dose. And at times you have to also stop one of these medications if the patient keeps having hyperkalemia. Then SGLT2 inhibitors, whether or not the patient is diabetic, the patient with HFrEF has to be on an SGLT2 inhibitor. The most important ones that we use are dapagliflozin and empagliflozin. Then for HFpEF, as such, we do not have class 1 recommendation drugs, but we have class 2A recommendation. That is, you can do is that SGLT2 inhibitors. This is the only class of drug that is nowadays used for all the patients with HFpEF, whether or not they're diabetic. Then other medications that you can use is hydralazine and a combination of hydralazine and isosorbate dinitrate. The good thing about this is that it has also shown decreased morbidity and mortality, especially in the self-identified African American patients. This combination helps reduce the morbidity and mortality. In other patients, like for example, if there's any contraindication, if the patient has renal dysfunction, AKI, in the patients in whom you cannot use ACE and ARBs, as I said before, for afterload control, you can use hydralazine, and you can also add isosorbate dinitrate. Then these are add-on therapies for the patient. Like for example, if you're not able to control pressure on the high tolerated doses of these medications in the patients of HFrEF, you can add calcium channel blockers in the patients with HFpEF for good afterload reduction. If you're not able to control it with ACE and ARBs, you're not able to control it with carvedilol, then you can also consider adding hydralazine calcium channel blocker. So these are some of the add-on medications. And then if the patient has now something that you have to remember is that if the patient comes in the hospital, is admitted for acute exacerbation, you diurese them, you give them fluid restriction. If this patient salt and fluid restriction, if this patient goes home, takes excessive amount of salt and water, they will keep having repeated episodes. So a lot of times you'll have to keep the patient on home loop diuretic dose, like for example, furosemide, to help them manage their body volume. Then digoxin has a class 2B recommendation in HFrEF. It helps reduce the hospitalization, but does not have any mortality benefit. Then some of the recent advances in the case of HFrEF, we have a medication called ivabradine. That it has class 2A recommendation. It is used for rate control in the patients in who are tachycardic in HFrEF. That is, you've used the maximum dose of beta blocker and the heart rate is still more than equal to 70, and they are in sinus rhythm. So these are the three important things you can be asked in rounds, that when do you use ivabradine. So maximum tolerated of beta blocker dose is already used, and then heart rate is still more than equal to 70, and they are in sinus rhythm. So you can use ivabradine. It has a class 2A, you can use in case of HFrEF. Then we have one more drug, variciguat, based on the Victoria trial, which you can read. It helps reduce hospitalization and cardiovascular death. It has a class 2B recommendation in case of HFrEF. So these are different classes of medications. Now, one other important thing, as I said, patients can be on home diuretic. One strategy that you can use is as needed diuretic dosing, loop diuretic dosing at home. So if the patient has a tendency of if you discharge the patient from the hospital and you think they have unpredictable salt and water intake, what you can ask the patient to do is get a weighing scale and weigh themselves every day in the morning. And if they see more than 2 pound weight gain over 2 days, or more than 5 pound weight gain over 1 week, you can tell them to take an extra dose of diuretic, loop diuretic. Let's say if they're taking furosemide 20 milligram daily at home, and they're weighing themselves every day and they see this weight gain, they can take one more dose of furosemide 20 milligram that day. Or if the patient is not is euvolemic at baseline, is able to maintain their salt and water intake, and they weigh themselves every day and they see this increase in the weight in the case of HFrEF, they can still consider taking one dose of loop diuretics that day. So this strategy has shown to have good outcomes in these patients if you're not giving them daily dosing, or if they're taking daily dosing, but sometimes it's not adequate, so, or unpredictable salt intake. So these patients can use this as needed dosing. All the patients, it's very important that they're counseled about their salt intake in case of heart failure. Now, coming to one of the final parts of this discussion is implantable device. Now, remember that the patients who have HFrEF, they have a high tendency of having VTAC and VFib. And if this patient is outside the hospital, and of course, nobody's going to carry a defibrillator with them, these patients, if they go into a VTAC, VFib, they can have a cardiac arrest and they can die. So the patients with HFrEF, we use implantable devices, an ICD, that is implantable cardioverter defibrillator, so that if they go into an episode of VTAC, VFib, these devices, the leads are implanted into the heart and it can shock the patient and get them out of these abnormal rhythms. Now, what is the criteria, which is very commonly asked in rounds and in your exams to place an ICD, is that ICD placement you will do if the left ventricular EF is less than equal to 35% and the patient is on medical therapy, GDMT, that is, as I said, ACE, beta blockers, MRA, SGLT2 inhibitors for at least 3 months, or they are more than 40 days post MI. So when the patient meets this criteria, you will go ahead and place an ICD. And then we have a cardiac resynchronization therapy, CRT device. I will tell you how that is different from an ICD. But the criteria to place that is that when the left ventricular EF is less than equal to 35%, same, the patient is on GDMT for more than equal to 3 months, or and more than 40 days post MI, and also has a left bundle branch block with a QRS more than equal to 150. So the same criteria for ICD plus the patient having a left bundle branch block with a QRS more than equal to 150, we have a class 1 recommendation to place a CRT device instead of an ICD. Now, what do you do in the patients who have a left bundle branch block, but the QRS is between 120 to 149? In these cases, you also have a class 2A. You can place a CRT device. If the patient does not have a left bundle branch block, but the QRS is more than equal to 150, you can still place a CRT device. It's a class 2A recommendation for these patients. Now, what is a life vest? Now, in this 3-month period, when between the patients being diagnosed with HFrEF and the patient using GDMT, there is a chance that the patient can have, between these 40 to 90 days, the patient can have a VTAC or VFib episode. So what we can use is a life vest. That is, it is a wearable defibrillator device, a wearable cardiac defibrillator. It looks like a jacket, which the patient has to wear on them. This jacket helps, it has pads and leads in it, so it can detect these episodes and can shock the patient when they go into VFib and VTAC. But there was a trial that was published called as the West trial, and it actually did not show any difference in the mortality in the patients who did wear it and did not wear life vest. But there are also important indications for life vest, which are not apart from this trial, is that if the patient has a lead, an ICD device placed, they have bacteremia, they have sepsis, infection of the lead, and for some reason the ICD is removed, these patients are temporarily kept on a life vest until a new ICD is placed, or in the patients who are awaiting a heart transplant. So even these patients are placed on a life vest. But remember that it depends on the consultants as well. A lot of patients have good compliance. A lot of patients do wear it as they are explained, and they have had benefit from the life vest. So a lot of consultants will still choose to give life vest in the patients in this interim period before an ICD placement. But because of the based on this trial, since there was no significant mortality benefit, a lot of times it's not used. But either ways, in the patients who have bacteremia, lead, if the ICD is removed, if they're waiting for heart transplant, life vest is still used. That was not a part of the trial. So this is something that you can remember. It might be asked in rounds. Now, I'll quickly go over how an ICD looks like, how you differentiate, because when you admit a patient, you can look at their chest X-ray and tell what kind of a device it is. And if the patient already has a device, comes in with acute exacerbation, you're admitting a patient, a lot of times you'll have to ask this question to the patient because the patient might have had shocks from the ICD. So you can always ask them, did you feel any shocks from the ICD? Because they might have had episodes of VTAC or VFib, and the ICD needs to be interrogated. You need to call to interrogate the ICD to see what rhythms were whenever you're admitting a patient with acute exacerbation. So on the X-ray, you can tell what kind of a device it is. Like, for example, This is a single chamber ICD, and you can see two coils over here. Now, this single chamber ICD, this has one lead that goes into the right ventricle, and it has two coils for shocking the patient. So this is an ICD single chamber. Then this is a single chamber ICD with one lead, one coil lead in the right ventricle. So single coil, single chamber ICD. Now, how will you differentiate between an ICD and a pacemaker is that you in a pacemaker, you will not see these coils like this over here, these huge coils on the X-ray. So this is an example of a pacemaker. So you can understand how it is different from an ICD is that a pacemaker will have these thin leads. It will not have those coils. Then what about a CRT device? You can see over here, a CRT device is the one that will have three leads. Now, a CRT device can do a biventricular pacing versus an ICD device, and it will have three leads. So every time you look at the X-ray, if you see one lead or two leads, it could be either a pacemaker or an ICD, but it will not be a CRT device. CRT device will always have three leads. That is one in the right atrium, one in the right ventricle, and you can see those coils, the shocking coil in the right ventricle, and one goes through the coronary sinus and touches the left ventricle. So these three leads tells you that this is a CRT device, cardiac rate synchronization therapy, and not an ICD. What is the difference between a bi-V pacing, a single chamber ICD, a dual chamber pacemaker? How are they different? How do they pace? How do they shock? This is something that I'll discuss in the sessions that follow, in the EKG sessions, when I'll be going over these different kinds of EKG. How do they look like whenever we do a bi-V pacing, a single chamber pacing, dual chamber pacemaker? So I'll go over in detail in those sessions. But for now, it's just for you to understand how do you identify the device when you're admitting a patient with heart failure. That's why I'm quickly going over these images. Then this is something that you can also see sometimes. It's a subcutaneous ICD in which the X-ray, you will not see the leads actually inside the heart, but this is in the subcutaneous tissue. It can detect and shock the patient if they go into VTAC, VFib. So this is a subcutaneous ICD. You will not see any coils. So these are the devices for heart failure. And just to before we end the session, I will quickly go over, as I said before, the indications of right heart cath in case of heart failure. When do we do a right heart catheterization? Now, there are certain indications for that. Now, right heart cath is a gold standard for diagnosis of HFpEF. Remember that HFpEF is more difficult to diagnose than HFrEF. When do we use right heart cath in the case of HFpEF? You can do something called as H2FPEF score, H2FPEF score, and this score basically stands. Now, H2FPEF score signifies H2, that is heavy for 2, hypertension for 1 score, AFib a score of 3, pulmonary hypertension 1, elderly 1, and then elevated filling pressures on the echo score of 1. So you could use a medical calculator and calculate this H2FPEF score for a patient in case of HFpEF. And if the score is 0 to 1, it is a low probability. If the score is more than equal to 6 to 9, it's a high probability for HFpEF. But if you have intermediate score 2 to 5, in those cases, you can proceed with a right heart cath and get a better idea of the dynamics and the pressures inside the heart. Now, the common places where you will do a right heart cath is, let's say if you're trying to diurese a patient comes in with HFrEF, is congested, and you diurese the patient, and there is no response to the diuretics. Patient is still significantly congested. You went up on the diuretic dose, and the patient is still congested. So in those cases, you can consider right heart cath, especially if the patient, you're diuresing a patient who is congested, and they have worsening kidney function, renal function, and you're not sure if is it the patient not responding, or if the patient's pump is failing, if the patient is proceeding towards cardiogenic shock, patient is having decreased perfusion. uh, in those cases, you can proceed with a right heart cath. If the patient is having some other component of pulmonary hypertension, some other type of pulmonary hypertension, patient has lung issues, COPD, other causes of pulmonary hypertension, which I'll be discussing in detail in the session of pulmonary hypertension. In those cases as well, you will need a right heart cath to differentiate. So let's say if a patient comes to you, you started diuretics, you see that the kidney function is worsening, you see the patient has cold and clammy extremities, you do a right heart cath, and then you find that the patient's CVP is elevated, but the patient's cardiac index and cardiac output is low. So in this case, you know that the patient will need diuretics, but you need to do inotropic assisted diuretics. You need to give the patient either milrinone or dobutamine, and then with that you can give diuretics. So this is an example how a right heart cath helps you. Let's say if the patient is very short of breath, you have diuresed the patient, he looks dry on examination, and then do you do a right heart cath, you see that the cardiac index and cardiac output is normal, the CVP is also normal. So you can, and there are some other parameters of right heart cath which I'll discuss later in detail in pulmonary hypertension. So this way it tells you that the problem is not the heart, it's something else. So that's how the right heart cath also helps you. Then in sometimes if the patient is having worsening renal function, if you do a right heart cath and you see that the CVP is low, and the patient is dry, you know that the patient is going significantly over the dry side, the renal function is worsening. In these cases, you can actually go ahead and give some fluids to the patient. So the right heart cath basically helps you in decision making in the patients who are HFrEF, especially in advanced cases of HFrEF, in which going towards cardiogenic shock, or they have significant pump failure and are candidates for left ventricular assist device, or are candidates for inotrope support, like for example a milrinone pump. In all these cases, the right heart cath actually helps you to decide in which direction to take the treatment. So I will discuss this right heart cath in much more detail with what parameters to see, the pulmonary capillary wedge pressure, cardiac index, cardiac output, how to calculate them, and how to interpret them in the session on pulmonary hypertension in the later lectures. Now, there are few common clinical conditions that you will come across in the hospital, especially also in the ICU, which you should know how to deal with. Like, for example, one of the common conditions is patient comes in with HFrEF, also has a history of COPD. Now, this patient is very, very short of breath. And now you have to decide, is the shortness of breath coming from heart failure or COPD or both? So number one thing is you will do a careful, you will be doing a thorough examination and assess the patient's volume status. And remember that wheezing can happen in both the cases, heart failure, exacerbation, and COPD. But if the patient is otherwise clinically dry, like for example, patient does not have peripheral edema, does not have a JVD, does not have a S3, you do a chest X-ray, it's clear. Patient does have a history of HFrEF, and they're having significant wheezing. So you know that the shortness of breath is coming from COPD exacerbation. Now, if a patient comes to you, has a history of COPD, is adherent with all his inhalers, the patient has a lot of edema, pulmonary congestion on the X-ray, has a JVD, is wet on examination. So you know that the shortness of breath is more likely coming from heart failure. But remember that there are patients who will have both heart failure exacerbation and COPD exacerbation. So one of the things that you can do in these cases is that you get an ABG and you get a better idea if the patient is having CO2 retention or not, and which condition to treat. And then you will also do a BNP. As I said, BNP has to be used, interpreted in the clinical context. If it is very, very high in the patient who does not have otherwise any other reasons for a false interpretation of BNP, in those cases, it tells you that the patient is definitely in heart failure. The reason it's important is that the management of COPD, like for example, if you give steroids to the patient in COPD exacerbation who also has a history of HFrEF, if you give beta agonists, the bronchodilators, who also has a history of HFrEF, it can worsen the HFrEF if it is misdiagnosed. So that's why it's a bit tricky over here, but you need to know definitely what is going on. Either the patient has both the problems or one of them, because the management is different and kind of opposite for both of them. So let's talk about in COPD, in the patients who also have HFrEF, you can consider tropium and tiotropium instead of beta agonist. But if the patient is in COPD exacerbation and you do have to use bronchodilators, like which is the mainstay of management, beta agonists. Remember that beta agonists can lead to increased episode of arrhythmia, tachycardia in the patient who has HFrEF, and also hypokalemia. But studies have shown that they do not affect the overall mortality. If you use it in a patient in HFrEF who comes in with acute exacerbation of COPD, the overall mortality is not affected, but they can lead to the worsening of HFrEF symptoms. So that's why it's important to know to differentiate whenever you're admitting a patient who is at risk of both who has a diagnosis of both the conditions. Then talking about the beta blockers in the patients, now let's say a patient has both the conditions COPD and is at risk of multiple acute exacerbation, and the patient also has HFrEF, and you have to use beta blockers for mortality benefit. So in these cases, you can use cardioselective beta blockers. The cardioselective beta blockers do not really affect COPD, but there have been cases where high doses of cardioselective beta blockers also have the potency to cause bronchospasm and worsen COPD exacerbation, but at high doses. So you have to look at the benefit versus risk. In HFrEF, it causes mortality benefit, so you have to use a beta blocker. So you can use cardioselective beta blocker like metoprolol succinate, because that has less chances of causing COPD exacerbation than something non-selective like, for example, carvedilol. But metoprolol succinate at high doses can also lead to bronchospasm. So that is something that you have to remember when you're admitting a patient. And then in patient who, if you're going to treat both, if the patient is severely congested, but also you're suspecting COPD exacerbation, a patient is significantly has wheezing, ABG shows hypercapnia. In those cases, if you're diuresing the patient as well, along with treatment of COPD with bronchodilators, you have to remember that these patients have a high chance of becoming hypokalemic. So you will monitor their labs and replete the potassium if you're treating both of them. Then talking about heart failure with sepsis or pneumonia. Now, this is a tricky situation, because remember that in HFrEF exacerbation, we're trying to diurese the patient, but at the same time, if the patient is septic, has bacteremia, or has pneumonia, we cannot put them on the septic having infection, pneumonia. So this is a hard condition to treat, because you also have to remember about the decreased perfusion from the sepsis itself in these cases. So let's say, for an example, if the patient has a history of HFrEF, comes in septic, has pneumonia, has an infection, and you think that the patient is on the dehydrated side. Now, these patients do need fluids, and you will give them 30 ml per kg like we do resuscitation fluid. These patients who are on dehydrated side are septic, should not be kept off the fluids just because they have a low EF, HFrEF, because it's associated with higher mortality. Because remember that a patient who has HFrEF, their heart is already not pumping the fluid forward in the pipes. And if these patients have a low intravascular volume and are septic, have decreased perfusion from the sepsis itself, and you do not give them fluids, they're going to have a higher mortality. So you give them fluids, but the only thing is, these patients have also high chance of going into volume overloads. They have to be carefully monitored. So the maintenance fluids, you can go down on them. You can give them lower amount of maintenance fluids, or you can choose to keep them off the maintenance fluids if they are adequately resuscitated. So this is a balance that you have to find between diuresis and giving fluids in the patients who have HFrEF, either exacerbation or are dehydrated, and come in with sepsis and pneumonia. So this is a tricky situation to treat. Then patients who have heart failure with AFib, I already went over this in my session on atrial fibrillation. If the patient is having heart failure with preserved ejection fraction, is not hypotensive, you can use non-dihydropyridine calcium channel blocker like diltiazem for rate control in AFib. If the patient is having HFrEF, you can, if the patient's blood pressure is on the normal side or a little bit on the higher side, you can use a cardioselective beta blocker, like for example metoprolol tartrate IV push for rate control. If not, you can actually also give them one-time dose if the pressure is not on the lower side. Sometimes some people will also choose to give them non-dihydropyridine calcium channel blocker, but non-dihydropyridine calcium channel blocker like diltiazem is usually contraindicated in the patients who have HFrEF, especially if they are in acute exacerbation and also have low blood pressure. So in these cases whose blood pressure is on the softer side, have HFrEF, or are also in acute exacerbation, these patients, you can also use digoxin, like I explained. I've done a detailed discussion on this topic in the session on the AFib. So the choice of rate control medication that you're going to use depends on the patient's condition. Then coming to the rhythm control, as I said in the previous session, some of the medications are contraindicated in patients with heart failure, like for example, dronedarone, sotalol. These are some of the medications you cannot use in the patients with heart failure. Some of the medications cannot be used, like for example, flecainide, propafenone in the patients who have structural heart disease. So that's why one of the common medications that you will come across in the patients who have HFrEF and AFib for rhythm control is amiodarone. So you can check that lecture for a detailed discussion on AFib and heart failure. Then heart failure with ESRD on hemodialysis. Of course, if the patient is coming in with acute exacerbation, they need to undergo emergent hemodialysis. One of the common things that you will deal in these kind of patients is that they have a very high afterload. A lot of times, patients have difficult to control resistant hypertension in the patients with ESRD on hemodialysis. So you have to be cautious about afterload control in these patients, because if they keep having high blood pressures and you do not control them, they will keep going into flash pulmonary edema body. So these are some of the conditions that you might come across, especially in the ICU settings, and they are challenging to treat. Then this topic is something that I will just superficially cover at this time, but I will go in detail when I discuss cardiogenic shock in another session. So a lot of times this is kind of a summary for heart failure management and when you assess the patient. So you will see a lot of times in your books that perfusion versus congestion. If the patient has good perfusion, poor perfusion, is congested and not congested. You have warm and wet, you have warm and dry, cold and wet, and cold and dry. So the patient is congested and has good perfusion, warm and wet. The management strategy, as I said, we diurese the patient and use vasodilators for afterload control and preload with nitroglycerin. So we control the blood pressure in these patients. This is how we'll manage it. And then in the patient who is not congested but has good perfusion, you will also look for other causes of the patient's shortness of breath and other causes of decompensation like sepsis, pneumonia. And then the patient who is having poor perfusion and is congested, then as I said when I was discussing right heart cath, is that they will need ionotrope assisted diuresis. You have to give diuretics to remove, but they will also require ionotropes like dobutamine, milrinone, which I'll discuss in detail in cardiogenic shock. And then the patients who have poor perfusion and are dry, the management strategies are ionotrope. You will see a lot of patients with milrinone pump, and you will need the patients, a lot of patients with advanced cases of heart failure, the patients will be on a balloon pump or Impala devices, which are usually a bridge to left ventricular assist device, artificial heart patients who are either awaiting a heart transplant, or a lot of times the patients will will not go into the route of palliative care, and for them it's just to prolong their life if they're not awaiting heart transplant. So a detailed discussion, I will do this in the later sessions. But that's all for the discussion on heart failure. Again, before I end the session, I would like to say that this lecture is based on my personal understanding and reading and my personal opinion on heart failure. I would highly recommend that you listen to this lecture like my other lectures and go and read up on these topics from different resources. And you can discuss this with your attendings and consultants and eventually make a decision on how will you treat the patient. None of my lectures, including this lecture, is for medical advice for the patients. So as I said before, the best way to become a good clinician is actually to go ahead and practice all these topics that you learn. Your knowledge is useless if you do not know how to use it in the clinical setting. So that's it for this session. Thank you for listening. Please share this lecture if you like it. Um, press the like button and subscribe to my channel. That's it for now. Thank you.